Hello, my name is Amanda Clemons, and I will be presenting my scholarly project, Identification of Adolescents at Risk of Obstructive Sleep Apnea in Primary Care. This project could not have been completed without the assistance of Dr. Jennifer Hepner, DNP Chair, Dr. Bonnie Stegman, Second Reader, and Dr. Jeffrey Fisher, Community Member and Medical Director at the clinical site. The purpose of this project was to evaluate the effectiveness of the Stop-Bang Screening Questionnaire in identifying adolescent patients with obstructive sleep apnea, or OSA. The aim of this project was twofold: early identification of OSA in primary care, and the prompt referral to sleep medicine with a resulting improvement in comorbidities for adolescents. OSA is the neurological or obstructive narrowing and dynamic collapse of the upper airway during sleep due to a combination of neuromotor and structural factors causing sleep disturbances. Adolescents present with hormonal and developmental changes that can increase the risk for OSA. And while they may have a more adult-like obstructive sleep apnea phenotype and overlap in disorder presentation, the clinical manifestations, polysomnography findings, diagnosis, and treatment are distinctly different from OSA in adults. There is between a 15 and 76% prevalence of OSA in child and adolescent populations. And there is a great significance due to the sleep health disparities. Sleep health disparities are impacted by socioeconomic status, discrimination, geography, access to health care, and cultural beliefs, which can contribute to health disparities and often go unrecognized. Disparities in pediatric sleep health require urgent intervention to reduce the risk of reduction in overall quality of life. Implementing tools, such as the modified Stop-Bang Screening Questionnaire, create a protocol to provide uniform screening of adolescent patients to assist in identifying those at risk for OSA and possible sequelae. It allows for timely referral to sleep medicine specialists, reduces the burden on health care, and reduces the potential sequelae of OSA for this vulnerable population, improving patient outcomes and satisfaction. The research of the CINAHL, PubMed, Medline Complete, Ovid, and Cochrane databases, including the parameters English language, peer-reviewed, full-text articles between 2011 and 2021, an integrated review of literature was developed. The studies reviewed had 4 common themes: sleep breathing disorders, pediatric OSA, complications of pediatric OSA, and OSA screening forms. The classifications of sleep breathing disorders in order of severity include primary snoring, upper airway resistance syndrome, obstructive hypoventilation, and obstructive sleep apnea syndrome. OSA is the most common form of pediatric sleep breathing disorders. OSA is suspected in 20% of children with reported snoring in primary care, and is often undiagnosed in teens, leaving them at risk. Pediatric OSA was recognized in the 2005 International Classification of Sleep Disorders, with the risk group evenly distributed over age and gender. Sleep breathing disorders such as OSA, if left undiagnosed and untreated, can result in not only sleep disturbances, but academic performance issues, behavioral issues such as conduct disorder, neurocognitive problems such as attention deficit and hyperactivity disorder, and an increased risk of cardiovascular and metabolic disorders in the future. Pediatric patients in primary care are not typically routinely screened for sleep breathing disorders. Providers need the proper training to screen, identify, and stratify the risk of OSA in adolescents. The American Academy of Pediatrics clinical practice guidelines include routine screening and appropriate referral for snoring for the referral of complex high-risk patients. This is especially important as parents may not readily recognize or report the symptoms of OSA. And there is currently a lack of screening efforts for OSA in pediatric patients, which may be attributed to a lack of concern and a low confidence level in the ability to diagnose OSA in primary care due to a deficit of knowledge of the prevalence of undiagnosed sleep apnea in adolescents. And while polysomnography is the gold standard for diagnosing OSA, it requires identifying the risk of OSA and referral to sleep medicine specialists. Implementing proper screening practices for teens in primary care is vital. This can be achieved by using risk stratification to identify high-risk patients and providing appropriate specialty referrals to prevent overwhelming the specialty practices, such as sleep medicine, with unnecessary referrals, thus reducing the burden on a valuable and sometimes limited resource. There are several validated sleep disorder screening tools available for use to assist in this. The stop-bang tool was originally developed to screen preoperative patients for the risk of OSA, and modifications to the stop-bang assess snoring, perceived tiredness, observed apnea, blood pressure, body mass index, academic problems, and neck circumference to identify and stratify risk for OSA in adolescent patients. The screening tool has been effective in other settings and improved the referral rate to sleep medicine specialists for diagnosis and treatment. It was chosen for its simplicity, brevity, and accuracy in adolescent patients. The theoretical framework chosen for this project is Becker's Health Belief Model, or HBM. HBM theorizes that a person's perception of a health problem's threat and the perceived value of the actions that will reduce the threat will influence health-seeking behaviors. Pollitt and Beck list the major components of the HBM as perceived susceptibility, severity, benefits and cost, motivation, and modifying factors. The HBM fits into the phenomenon of interest for this scholarly project as it concerns screening for OSA in adolescents that often goes undiagnosed and untreated in this population. Identifying the risk of OSA can in turn affect health-seeking behaviors as screenings create an opportunity for conversations regarding the potentially dangerous sequelae of OSA in adolescents, as well as ways to correct the increased risk of OSA, such as obesity. The screening process also addresses the HBM components of perceived susceptibility, severity, and benefits regarding OSA, sleep medicine referrals, and treatment explicitly related to the patient based on the screening results. The HBM components of perceived cost can present a barrier, as polysomnography and a visit with a sleep medicine specialist can be costly. However, the screening process can aid in stratifying the risk of OSA and in turn mitigate cost and motivate to follow through with a referral and further testing or treatment. The modifying factor of patient satisfaction can be affected by improved patient health outcomes through early identification and referral for testing and treatment. The methodology used for this project included a quantitative research design using a retrospective chart review to collect data to compare the frequency of screening and referral rates to sleep medicine specialists before and after implementation of the modified stop-bang screening tool. The participants were not engaged or recruited. An educational workshop was held for the staff and primary care providers to include the current concerns regarding adolescent OSA and to introduce the modified stop-bang questionnaire. This project was held in a family medicine urgent care hybrid clinic in Mansfield, Texas. The primary care providers include both nurse practitioners and a physician, and the patient population spans across the lifespan from 6 months of age and up. A convenience sample was obtained from the electronic medical record, or EMR, used for data collection. The predetermined sample size was 154 EMRs, 77 before and 77 after implementation, between January 2nd, 2022 and April 30th, 2022. The inclusion criteria for data collection required the subjects to be 13 to 18 years of age, being seen in the clinic for a well exam. The exclusion criteria included anyone under 13 or over 18 years of age, or those within the age range being seen for sick complaints. The sequential inclusion and exclusion process continued until the suggested sample size of 154 EMRs was met. While gathering evidence, the appropriate steps were taken to protect the subjects of the scholarly research study and to prevent a breach of confidentiality. Beyond the minimal risk of breach of confidentiality, there was no expected risk of the subjects in the retrospective chart review. A waiver of authorization form was obtained to comply with the Health Insurance Portability and Accountability Act Privacy Rule, or HIPAA. Each EMR was assigned a numerical number on the data collection sheet, and the de-identified data was stored on a password-protected file on a password-protected computer, and access was limited to the researcher to comply with HIPAA. The chart you see provides a look at the socio-demographic traits of the subjects involved in the study. The study included both males and females, aged 13 to 18 years of age, and the races that presented to the clinic during the study included African American, Hispanic, white, and Asian. The demographics are fairly consistently presented both pre and post implementation of the screening questionnaire. To determine if there is a statistically significant impact on screening and referral rates to sleep medicine specialists after implementing the standardized screening for OSA in adolescents, the z-test for the difference of two proportions, a special form of chi-square, was used in the statistical analysis. A power analysis was done to reduce the likelihood of type 2 errors, determine the data results strength, and visualize the degree of variability expected with implementation. It yielded a strong study rejecting the null hypothesis of no change. And to achieve at least a medium effect, the sample size required was determined to be 154 EMRs. Patients who were screened for OSA were found to have significantly more positive rates of referral to sleep medicine specialists than those that were not screened. As the p-value of this study was less than the significance level of 0.05, it was sufficient to suggest an increase in the ratio from pre to post intervention. And the confidence level of 95% indicates a true change in pre and post intervention. As demonstrated in this graph, before standardizing practice, only one screening was done, resulting in a referral to sleep medicine. After implementation of the stop-bang screening questionnaire, there were 18 patients identified with an OSA risk score of greater than or equal to 4, resulting in a referral to sleep medicine. As you can see from the graph, there was a marked increase in the rate of screenings done, the rates of identification of adolescent patients at risk for OSA, and the referral rates to sleep medicine specialists. When discussing limitations, the project relied on providers to ensure documentation of the intervention, and it is feasible that screenings were done during patient encounters and not documented, particularly pre-intervention. This project was also limited to a single clinical site. This limits generalizability to other family practice clinics, even if the project design was intended to be reproducible. A larger cohort, including different ethnicities, would be helpful as the study included predominantly African American, Hispanic, and Caucasian patients. There is also the possibility that this change in practice may not be sustained, and collecting data at intervals of 6 and 12 months would be beneficial. And while the limitations require noting when interpreting the findings, they do not decrease the significance of the results. The most significant barrier included the high turnover rate of medical assistants in this clinical site, and there was a significant turnover during data collection post-intervention. Education of the new hires on the purpose of the project and the screening tool was required to ensure it was done correctly. The facilitators of this project were the clinical staff. The providers were cooperative in conducting and documenting the screenings post-intervention, and the medical assistants that retained employment assisted in providing the necessary training for the new hires so data collection could proceed without an issue. The findings of this study demonstrated that standardized practice for screening for OSA in adolescents through the use of the modified stop-bang screening questionnaire improved the number of patients screened and rates of referral to sleep medicine specialists in a family practice setting. Overall, there was an improvement in identifying at-risk patients and referral rates to sleep medicine specialists. These findings are not unique to the scholarly project. The results of this scholarly project both strengthen the current evidence and support a need for a change in current practice. Interpretation of the data revealed significantly more adolescent patients identified as at risk for OSA and referred to sleep medicine after the standardization of practice through the use of a screening tool. The findings were in line with the anticipated outcomes, and the literature supports the use of screening tools and practice standardization to improve patient outcomes. Limitations of the study should be the focus of future research. Conducting research in multiple family practice clinical sites would assist in enhancing generalizability, A larger sample size would assist in assessing validity. Collecting additional data at the 6 and 12-month marks would determine the intervention's sustainability. The scholarly project also justified implementation of the use of screening tools to standardize practice regarding screening for pediatric OSA, as it was demonstrated that standardized screening improved the identification of the risk of OSA and referral rates to sleep medicine in adolescents, who are still counted in the pediatric population. This could be accomplished through provider education on the need for pediatric OSA screenings and implementing screening tools for standardized practice in the family practice setting. The inclusion of a screening tool and provider prompts in the EMR would be helpful in the achievement of this recommendation and improve sustainability. This intervention would impact practice and improve pediatric patient outcomes in the family practice setting. This project has implications for practice in the areas of research, healthcare policy, and quality and safety. This project supports the implementation of a screening tool to standardize practice for improving rates of identification and referral to sleep medicine specialists for adolescents at risk for OSA. A future research topic could be the effect of provider education on improving pediatric OSA screenings. Untreated pediatric OSA is a concerning public health issue, and this scholarly project demonstrated a need for change in practice and a shift in healthcare policy to compel healthcare providers to screen for pediatric OSA routinely. Inclusion of education regarding the health concerns and the importance of screening pediatric patients for OSA in learning institutions would be incredibly beneficial for advanced practice nurses and medical doctors. Improving identification and referral for management of sleep apnea in pediatric patients are also pertinent to the quality of care. I am proud to say that this project successfully demonstrated that standardized practice for routine screening for the risk of OSA in adolescents improves screening and referral rates to sleep medicine specialists. When reviewing practice after the project was complete, I discovered that the use of the screening tools had continued to be standardized practice for only 2 of the providers, one of them being myself. And the other 2 providers in the clinic use it intermittently. This led me to consider what I would do differently. If I were to conduct a similar study in the future, I feel like I would work to have the screening tool or intervention of choice included in the electronic medical record, as well as a prompt included in the system to assist in promoting consistency, because you're more inclined to use it if you have a reminder to do so. I would also work to recruit other clinics in more ethnically and financially diverse areas to be included in future research to help improve generalizability. You want to know that your project works across different populations and different socioeconomic statuses. In conclusion, this project allowed me to affect change using evidence-based practice. As a nurse, especially an advanced practice nurse, this is exciting, and it builds confidence in my ability to affect change in nursing in the future. Personally, I plan to continue to screen my pediatric patients for the risk of OSA in my practice to allow for the best possible patient outcomes in this population. I've also started using other evidence-based screening tools in other patient populations to screen for things like anxiety, depression, and fall risk routinely. It is crucial as an advanced practice provider to stay current on evidence-based practice and to actually put it into use. When reflecting on my journey through the Maryville DNP program, I will admit that it has been both rewarding and oftentimes a struggle. I have learned so much more than I anticipated. And this program has shown me that I am capable of more than I ever imagined, and has helped me improve my skills as an advanced practice provider and given me tools to improve outcomes for my patients. And it also made my family pretty proud. Definitely worth every sleepless night. I would like to give so many thanks for you taking time to listen to my presentation today. And if there are any questions or comments, please feel free to contact me. My email address is aclemons1@live.maryville.edu. Again, thank you so much for your time and have a wonderful day.